So can the timer start? Here I go. So the topic for me is cardio-renal metabolic approach for type 2 diabetes management, role of SGLT2 DPP4 fixed dose combination. So it is a very common garden topic, not like the exciting topic you heard about semaglutide or about erectile dysfunction. It's a very simple day-to-day topic. Now, whenever you think about type 2 diabetes, I have to apologize to Dr. Jumani. I don't have erectile dysfunction here. I should have it next time. So when you see somebody with diabetes, they're not only managing the blood sugar, but you have to take care of blood pressure, lipids, uric acid. NASH is a big thing. Many of them have associated hypothyroidism. So you have to take care of those issues, and you're managing to prevent complications, acute complications, DKHHS, and chronic complications, which are micro and macrovascular, which is retinopathy, nephropathy, neuropathy, cardiovascular disease, and PVD. So when I focus on nephropathy and cardiovascular disease today, please don't forget PVD, stroke, erectile dysfunction, neuropathy, retinopathy also add to disease burden. But why do we focus so much on cardiovascular and renal outcomes is because majority, the chunk of morbidity and mortality comes from the cardio-renal aspects of type 2 diabetes. Now, before I jump into SGLT2 DP4 inhibitor combination, please don't get me wrong. We just by adding an SGLT2 DP4 inhibitor, which is primarily using for glycemic control, maybe a little bit for weight control, very minimal effects on blood pressure, you're not going to win the war. Type 2 diabetes management is a holistic management. You need to have your dietitian or you yourself give diet advice. You need to have your trainer motivators. You could be the one. Patient has to exercise. Dr. Jumani was stressing, and I will double stress it, that lifestyle modification is the key to managing type 2 diabetes. They need to monitor their blood sugars depending on what type it is. And then comes you and me, the physician. We are a small peg. In India, unfortunately, we have to play a major role because many of you have to be all three put together, especially in the peripheries. We in the tertiary hospitals have the luxury of having this paramedical staff to help us. You need to think about blood pressure control. You need to think about lipid control. You need to get them off smoking, reduce their alcohol, and get it into their head from day one that diabetes is not a mild disease, it's a serious disease, and you are in the business of preventing complications. Sugars are just a marker. And I am a very strong proponent of early use of combination therapy, possibly with newer OADs, and that's where I'm going to go now. Before I zoom in again on this combination, just to remind you, this slide you have seen 100 times. You can add there are many takes out of this slide. My take here is good glycemic control achieved early in the natural course of diabetes has a long-lasting effect. And I will not repeat the slide which you know very well. But just by doing glycemic control, you will not win. As I was suggesting, it has to be holistic management. This is a famous slide from the STENO2 trial, which tells you that along with glycemic control, you need your blood pressure control, you need your lipid control to get this fascinating benefit of reducing the first CVD event or death by 8 years. These STENO2 only use sulfonylurea, which was gliclazide, metformin, and human insulins. There were no DPP4 SGLT2 inhibitors when STENO2 was designed and STENO2 was done. So don't lose heart. So first build your cake layer by layer. Get your blood pressure control, lipid control, sugar control, whatever agent you have. Now, on top of that, what further can you do? The reason why we're talking it is this Discover study program. Please read about this. There's a lot of papers coming out of this Discover study program. What it tells you is what we all know, that glycemic control is really quite pathetic. About 17% in the Discover trial. You take the ICMR study, about 29 odd percent get glycemic control. So we have medications, we have doctors, we're talking about diabetes for so many years, but we still do not get glycemic control. There are many reasons. We promptly blame the patient promptly blames the doctor, the doctor and patient promptly blame the society, the government, the non-availability of A, B, C, D, E. So there are many reasons. I'm not just saying that the next slide is the only reason why you are not getting good glycemic control, but one of the reasons is inertia. I am guilty, you are guilty, we all are guilty. Partly because all the previous ADA, ESD guidelines, which majority of us in India follow, We now have very fantastic guidelines. The ESI RSSDI guideline just published 2020, just a few months ago. Let's follow the Indian guidelines. What the ADHD guideline ingrained into our brain was the stepwise therapy. This is a stepwise therapy to failure, my friends. And we are realizing that after so many years, because this leads to clinical inertia. So before we start the combination, what do we already know? Diabetes is a complex progressive metabolic disorder. There's inexorable loss of beta cell function. If you want to preserve these cells, hit early, hit hard. Glucolipotoxicity contributes to this. Therefore, you have to hit them early. Achieving tight glycemic control early protects beta cell function. Don't ask me, there's enough data. We can discuss that later. Tight glycemic control reduces microvascular UKPDS, possibly macrovascular UKPDS extension data. Clinical inertia, I've just shown the slide before, is an important factor, not the only factor, important factor in failure to intensify therapy. Adherence and compliance are an issue. You'll be surprised. You write such lovely long prescription, patient comes back to you, and if you really start digging, you will find that about 1/3 of those drugs from the prescription are either being bought, not being bought, staying in their drawer. They are not going into the patient's system. Weight gain and hypoglycemia always has been hindrance. When we were training, we were having sulfonylurea, human insulin, weight gain and hypoglycemia was an issue. Now you have drugs which do not cause this problem. And we all know that individual therapies will fail because the famous tick sign that you saw in the UKPDS study, in the what was that study? I'll come to it later. There's an inexorable decline in beta cell function. So each individual drug is going to fail. So we need to change our approach to managing type 2 diabetes. People along the world have been shouting this for the last 10 years, but we are waiting for this holy of the holy ESD, ASD, ESI, RSSDI to accept this concept that please start early combination therapy. Every other disease we are doing combination therapy except in diabetes. Why, I still do not know. I am 100% confident it's going to change. It's already changing. I'll show you how, but changing very slowly. It should change fast. When you are using a combination therapy, set your target. Choose a combination that addresses the core pathophysiological defects, have an additive effect. They are CV neutral or beneficial, weight neutral or beneficial, and they are safe. If you want, you can just take a picture of this slide. Just Google Subir and Dr. Mukherjee, Subir, my colleague. We have written a number of articles of the benefit of initiating combination therapy in people with newly diagnosed type 2 diabetes, including a chapter in Dr. Sadiko's textbook of diabetes. And when I said things are changing, they are changing, but they're not changing fast enough. I hope things change fast enough. Now look at the ADA-ESD 2018 guideline, which gets upgraded every year in the standards of care in ADA. And now they have reluctantly added that if HbA1c level is more than 1.5%, start combination therapy. I disagree with that. Why more than 1.5%? Even with an HbA1c of 7%, I'll start combination therapy. I'm not aiming just glycemic control. I'm aiming cardio-renal benefit as well. Getting glucose control alone is not going to get you to win the battle. AAC and ACE, people, we snicker about it, but they are probably the most progressive of all the guidelines as we have today, because they start allow you dual or triple therapy when HbA1c is more than 7.5%. And RSSDI ESI guideline equals the ADA-ESD statement as of now, using combination therapy when your HbA1c is more than 1.5. What we already know of all the drugs that we have. Metformin still remains the one. You have had a few lectures. So don't ask me why should metformin be one or SGLT2 be number one. We can have a debate on this and nobody will win. I would still say metformin remains number one. After that, to me, the best drug would be a GLP-1 receptor long-acting agonist. Oral semaglutide, when it comes, we'll think. You just heard Dr. Sujay Ghosh presenting that. But majority of the patients cannot afford a GLP-1 RA agonist. Everything is green here, if you see. Efficacy, hypoglycemia, weight gain, CV effects. Disadvantage, I think, instead of all this, I think there's a big 4-letter word called cost. SGLT2 inhibitors, they have proven themselves to be the best combination to start with metformin many a times now. And the things are listed there. Then probably comes DPP4 inhibitors. No matter how much we say against sulfonylureas, they still remain the most common second-line drug added after metformin worldwide. Highest in India and some other third world countries, but even in the advanced economies, sulfonylurea is still the most common second line drug. Many reasons, but there are a couple of issues with regards to hypoglycemia. We all have used sulfonylureas. We know that weight gain, maybe not that much with modern sulfonylureas. Cardiovascular safety is probably uncertain, but you could now say that Dr. Mukherjee with Carmelina study, probably glimepiride is safe. What are the pathophysiological defects? I won't bore you with this. You must have seen this 101 times. What I'm going to tell you is, if you take metformin and a GLP-1 or a DPP-4, GLP-1 more than DPP-4, and add an SGLT2 inhibitor, just see all the 8 pathophysiological defects. You will see GLP-1, metformin, DPP-4, GLP-1, DPP-4, metformin, SGLT2, incretin. Maybe the neurotransmitter function is still an open, the Pandora's box still to be opened. But other than that, you are targeting most of the pathophysiological defects if you're using a combination of a metformin and incretin. And when I say incretin, injectable is a bit difficult, so probably it has to be an oral DPP-4 and an SGLT2 inhibitor. Commonest combination used in the world is metformin SU. It's powerful, early efficacy, but you do not have any weight BP reduction. Rather, you may have some weight gain. You do not have any specific CB renal benefit. When you add sulfonylurea, metformin may be having a little bit of CB benefits, and risk of hypoglycemia is high. If you are using a metformin DPP-4 combination, not as powerful, but risk of hypoglycemia goes quite low, but you do not have anything covering these 2 quadrants of this cartoon. Now, if you're using a metformin, SGLT2, and either a DPP-4 or a GLP-1, henceforth, for an incretin, I'll be saying DPP-4. As I said, GLP-1 is not affordable for most of the patients. So if you're using a metformin, SGLT2, and a DPP-4 inhibitor, you're covering all 4 quadrants. So what is stopping you from using this combination? This is the modification of what we wrote in our chapter. We are suggesting using the dual therapy even between 6.5 to 7.4, not the ADHD guideline. Don't quote this. This is not quoted by the reputed bodies as of yet, but you are not treating a diabetic just for glycemic control. For heaven's sake, even in the pre-diabetic stage, even in the IGT stage, they have such high cardiovascular and renal risk. So why are we waiting for the heart and the kidney to deteriorate before we start treatment to prevent the retardation, prevent the deterioration? Let's get it to a point where they don't start deteriorating. That's why we're suggesting combine a metformin and a GLP-1 or a metformin and SGLT2. And then we've suggested various other combinations that is not part of this talk. So hopefully I've now convinced you that we need to start early combination therapy. Which combination? I have given you the options: metformin, SGLT2, and incretin. The best is the DPP-4. Why? Because DPP-4 and SGLT2 come in a pill. GLP-1s are in a tablet till oral semaglutide comes. So these are the various combinations available worldwide. Empalina, Dapacexa, and Ertusita. Ertusita is not available to us. It's available in the US and in the European market. We have Empalina and Dapacexa with us. DCRJ approval was available quite early for Empalina, a little bit later for Dapacexa, and commercially available. So always the person who comes first into the market does better because they were the first one with this combination. And that's why you see probably the market share of this combination is much more than the other one. So if you are using persistent and adherence, as I said, many of our patients do not take their medication for many reasons. Let's not go into that. So if you take a fixed dose combination, wherein Indians are masters in this. We Indians have been using fixed dose combinations for a long time. All this research is coming from the West later on. Later on, what is suggesting is of course your persistent and compliance is much better. So now if you use an SGLT2 DPP-4 inhibitor combination as opposed to metformin DPP-4 combination, you see you get a better HbA1c reduction, better weight loss because they're adding an SGLT now on somebody's already on a DPP-4, fasting, PP, blood pressure, about a ballpark figure of 4 millimeter. Here they had about a 6 millimeter drop. So everything improves. Similarly, on the other hand, if somebody is already on an SGLT2 inhibitor, if you add a DPP-4 inhibitor, the HbA1c reduction is not as good as adding the other way around, but still you get all the benefits of further HbA1c reduction, further body weight reduction, etc. all along. So If you are using a combination of an SGLT2 DPP4 inhibitor in the background of a fixed dose combination, Lina alone, EMPA alone, and when you're combining EMPA, Lina, you can obviously see that there is a better HbA1c reduction on a metformin background. So metformin SGLT2 DPP4 inhibitor. Not only that, it depends on your baseline HbA1c. As Dr. Sujay Ghosh was mentioning, any diabetic drug works much better if your HbA1c is high. It brings down the HbA1c more as compared to when you start with a baseline HbA1c of 7, about 8%. There, you will get an HbA1c reduction of about 1%. These are points I can't remember, 1%. And here you will get a ballpark figure of reduction of HbA1c of about 1.6 to 1.8%. Rings a little bit like the oral semaglutide talk you just heard from Dr. Sujay Ghosh. Not only that, you're using two drugs, so your HbA1c reduction happens quicker, faster, whether you use it in drug-naive patients, but generally you will not be using an SGLT2 without having a metformin background. So maybe this slide makes more sense. And look at the rapid drop in the HbA1c and much more than if you're using Lina-EMPA alone, as opposed to when you're using a Lina-EMPA combination. Percentage of people getting an HbA1c of less than 7%. Now, this is in the trial setting. Your real life experience may not match with this, because here the patients are being followed up very closely. Diet is being taken care of. They are having too many contacts with the healthcare system, so they get better results. So if you see number of people having an HbA1c of less than 7% up to 55 to 60%, depending on what dose you are using, and similarly on metformin background, 61 to 57.8%. This is the added benefit. We all know that SGLT2 inhibitors cause GTI, but when you use them in combination, for some reason, the risk of GTI goes down, as opposed to using EMPA alone when you use EMPA-Lina in combination. So coming to the cardiovascular benefits and the renal benefits, these slides you have seen many times. That's why I'm not going to spend much time. The four main cardiovascular outcome trials were the EMPA-REG, CANVAS, DECLARE-TIMI, and VERTIS. The only one which has got all the boxes ticked is the EMPA-REG outcome. Reduction in the hospital and heart failure, reduction in CV death. This is what is the crown, the jewel in the crown for empagliflozin, which the others do not have. 3P MACE benefit was with EMPA and CANVAS, whereas DECLARE and VERTIS, they were not bad, but they were non-inferior. They did not do harm, but they did not show benefit, did not show superiority. Now, renal outcomes in these cardiovascular outcome trials were a hypothesis generating, tertiary outcome. They were not looked at carefully, but whatever were the clinically relevant outcomes, which is reduction in GFR, renal replacement therapy, or going into ESRD, there was very impressive reduction with EMPA, CANA, and DAPA. ER2 failed to get that. If you see the ER2 upper limit crosses 1.04. Coming to CV and renal outcomes with DPP4 inhibitors, you have heard this many times. Heart failure increased with Saxa, not with Sita-Lina. CV death, there was no harm, no gain. 3P MACE, there was no harm, there was no gain. The renal outcomes with Saxa and Sita are basically, they were not pre-specified. There are secondary to the extent tertiary outcomes. There was reduction in albuminuria with saxagliptin, but it was not the primary endpoint. But with Carmelina, we all know that there was unequivocal pre-specified outcome, and there was no benefit in renal outcome, but there was benefit with regards to reduction in albuminuria. If you're using vildagliptin, you can use it for glycemic control, but you do not have a cardiovascular outcome trial. You have lots of meta-analysis of their small studies. VIVID trial unfortunately went in the wrong direction. There was increased LV volumes. It was a very brave study, VIVID study. Teneligliptin, again, if you're using it for glycemic control, use it. Just be careful about the QT prolongation. So don't use it in people who have got a risk of having QT prolongation. Hypoglycemia is the strongest risk for QT prolongation, and they do not have a CVOT. Of course, you cannot compare all these studies the way it has been compared in this slide, because they are done on different populations, different inclusion exclusion criteria. But if you put them in one slide, you can visualize the information easily. Now, coming to the individual outcomes of cardiovascular outcome trial, MACE is the 3P MACE. We all know superiority is green, non-inferiority. They were not harmful. Any of these were not harmful. Even saxagliptin was not harmful with regards to 3P MACE. It was only increased risk of heart failure. Only two have got green boxes, which was EMPA and Canvas. Declared Timmy and Vertis did not get the 3P maze. As to why, we can discuss that in question answer time if we have a question answer if we have time. CV death, as I said, only empagliflozin got it. The others did not get. With regards to the DPP4 inhibitors, there was no increase in CV death. They were neutral. Coming to heart failure, hospitalization due to heart failure, it's a class effect with regards to SGLT2 inhibitors. Even Vertis CV, which did not get anything else positive, had a positive superiority reduction in hospitalization to heart failure, and here saxagliptin loses out 27% increased risk. I think I will leave these two. Now let's come to this master slide. So what are the approved SGLT2 inhibitors? Empalina, dapasexa. Many of us are using separately, not in a fixed dose combination. So you lose out the benefits of a fixed dose combination, which is adherence and compliance, and dropping out from persistence. But you are using an SGLT2 DPP4. So let's compare. EMPA has got 3P maze benefit, CV death benefit, HHF benefit, renal risk, hepatic may be given, not in of course child stage 3C, and it's once daily. Lina, neutral, renal, there is a potential benefit in albuminuria reduction. DAPA, neutral 3P maze, neutral CV death, reduces HHF, reduces renal outcomes, and they have now a DAPA CKD study, which unequivocally showed in the CKD population that it reduces hard renal outcomes. But when you combine it with Saxa, you are bundled with this increased risk of heart failure. Remo, you are using it for glycemic control. Go ahead and use it. They are quite good at par with the other SGLT2 inhibitors. But you cannot tell your patient with confidence as to what's going to happen to the cardiovascular outcome trial. If you say it's a class effect, unfortunately, what is CV completely made us think differently. Because we had expected the same results with orthogliflozin as we had got with empagliflozin. The trial population was same, all 100% had established cardiovascular disease. Did not happen with orthogliflozin. Why? It's a Pandora's box. If you ask me, I will hedge. Vildagliptin again has no CVOT, and there was some issue with increased LV volumes in the VIVID trial. Of course, you know that if SGPT is raised, you cannot use a vildagliptin. So if you're using a fixed dose combination for its benefits, cost is less. When you combine them, I think it's very nicely written here. You get a metabolic benefit of up to 1.8% reduction, but don't get carried away. That's only for HbA1c is at 9%. You will get an HbA1c ratio of about 1% or 1 to 1.1% if your baseline HbA1c is 8%. You get significant pleiotropic benefit. We all know the SGLT2 data. CV perspective, with empagliflozin, not only get 3P maze, but CV death benefit, but in people with established cardiovascular disease, reduces all-cause mortality. And now you have the emperor reduced and the emperor preserved, which shows that there's benefit in both groups. Renal perspective, EMPA's specific study with in patients with renal impairment is not out yet. EMPA kidney is still ongoing, hoping for the results to come out pretty soon. But other molecules in this group, DAPA CKD has come out, and it shows clearly reduction in renal outcomes. And the EMPA-REG outcome trial, the secondary tertiary outcome, suggested there was clinically significant reduction in various renal outcomes. So if you're using EMPA-LINA combination along with metformin, I hope you remember in the beginning I said it's not only glycemia, but blood pressure, lipid, holistic management, protecting the organs. So from a glucocentric approach, I would not use the word holistic approach here. The holistic approach also includes lifestyle modification, cessation of smoking, moderation of alcohol intake. So it's not holistic approach, but it's drug-wise, pharmacological, you're coming to as holistic as possible. So this is my last slide. I think I won't read out. I will hand it over to the organizers while you all read through it. Thank you very much.
Thank you so much for that enlightening session. It was indeed a great session to learn from you, actually. And we'll take the questions at the end of the session. And I will hand over the session to Dr. Pradeep Ganguly, who is our next.